Optimal management of advanced renal cell carcinoma is not clearly defined, and recent developments have further complicated treatment choices. Two noted oncologists, Dr. Brian Renal from the Cleveland Clinic and Dr. Nicholas Vogelsang from the Comprehensive Cancer Centers of Nevada, discuss why this uncommon cancer is raising so many questions.
I've been out of fellowship about 15 years. In that time, there have been 10 drugs FDA approved for kidney cancer, including three in the last 12 months or so. So we kind of had the first wave of targeted therapy maybe 8 to 10 years ago, and now we have sort of this wave of immune therapy and other therapies.
The biggest question is what should be the sequence. I've written about this extensively, I've given interviews on it, and what we did most recently was take a group of practicing docs in the U.S. Oncology Network, put together what we thought was sort of a consensus, and we agreed on first line, second line, third line. But as we were finishing the review article, suddenly nivolumab got approved, and then cabozantinib, and then lenvatinib got approved. Within a matter of 6 months, the review article had become outdated.
As we get more drugs, integrating them into clinical practice becomes more challenging. Just the sheer volume of drugs that we have, which is a good problem to have.
Renal cell carcinoma accounts for 3% of adult malignancies. Although the rate of new cases has risen since the 1990s, the death rate has started to fall, and in metastatic disease, median survival has started to improve.
It's the starting dose, okay? Now you're small and relatively not in the pink of health, but you're not bad. Renal cell patients who used to have a survival of, on average, less than a year, the average patient is now in the 30 to 40 month survival rate. So we've seen almost a quadrupling of the median survival.
I usually quote patients about 3 years or so for average survival now. I think when we see the overall survival from these large frontline trials, I won't be surprised if it's 3 years plus. It's okay, but it's still not great, right? 3 years doesn't sound great to anybody.
Sadly, we're not curing most of those patients. They continue to get benefit from the drugs, but they don't enter remission.
The difficulty in establishing a durable remission in renal cell carcinoma is linked to the disease's genetic heterogeneity and lack of any targetable biomarkers.
The cancer is evolutionarily complex. It is able to display a number of genetic variants. The simplest mutation in renal cell is right at the VHL gene. That's a fairly clear, simple mutation. But as the chromosome damage becomes larger around that chromosome 3 region, you get genetic mutations called BAP or BAP, and that leads to much more genetically unstable disease, more poor risk disease, harder to treat. We don't yet have a full genetic landscape of the cancer, but we do know that the narrow mutation patients do much better than the broad mutation patients.
Unfortunately, in kidney cancer, we don't have really any useful biomarkers, despite many, many years of looking. HER2 status in breast cancer would be a great example of a biomarker that happens to be both prognostic and predictive. But when it comes down to me knowing if the patient expresses this marker, I'm going to give them drug X, and if they don't, I'm going to give them drug Y. And we just don't have that yet in RCC. Patients want to know which therapy is quote-unquote best for them, and we don't really know which one is best. We can guess based on trial data and patient characteristics and things like that, but at the end of the day, it's a guess. We give it and we see what happens.
Kimberly Allman, a nurse practitioner at the Cleveland Clinic, finds that patients with metastatic renal cell carcinoma often do not understand the implications of their diagnosis.
I've had many patients independent of their educational level, kind of question, what metastatic means, and it's news to them that they have an incurable cancer.
And I'll just ask people, what do you want me to tell you? I'll tell you everything you want to know, but some people don't want to hear it. They don't want numbers and median survival and things like that, and other people want the nitty-gritty detail, and they've been on the internet and they've looked up studies. In terms of managing expectations, if I'm starting somebody on, say, a targeted therapy, which is standard, I tell them this is not curative. Our goal is to control disease for as long as possible. We hope that changes over time to a more curative approach, but as of now, it's important that they understand that this is going to be an empiric sequence of therapies.
I had a sad case the other day where a young fellow from San Francisco with poor risk disease, granted poor risk, said he just wasn't up for the fight and just decided not to have any treatment and died 6 weeks later. So it's still a very tough disease for some patients. And it is a burden to be treated. It's pills, it's IVs, it's doctor visits. There's plenty of things not to like about the current treatment. But it's a life-extending therapy.
Join us next time when we examine how risk assessment can inform the optimal choice of therapy for patients with renal cell carcinoma. From different regions in the United States and differing practices, two renowned oncologists discuss essential aspects in the approach to renal cell carcinoma.
Before we had a lot of diagnostic tests, we used to call kidney cancer the internist's tumor because it would display such a variety of symptoms, from high calcium levels to lumps in the thyroid to neurologic disease. Now, a CT scan is the most common way it's diagnosed, usually for nonspecific symptoms or weight loss. I had one fellow, a physician, whose family has been afflicted with kidney cancer in China, and he just asked for a CT scan. He said, I've had a long family history. I need to be careful. And sure enough, he had a big 11-centimeter mass, and he was asymptomatic. So it can be very subtle and very quiet.
The application of local therapies to metastatic kidney cancer is something that has been part of the fabric of treating kidney cancer patients, and I think is becoming more so. So the classic example would be debulking nephrectomy. So it's a local therapy in the setting of metastatic disease that has proven survival advantages and is very much part of how we approach patients.
There were two very important studies in the 80s done by the Southwest Oncology Group and by the European Group that showed that removal of the kidney, regardless of what was subsequently done, led to improved survival. There was a diminution of interest in the removal of the kidney as we got drugs such as sunitinib and pazopanib, and people began to say, well, maybe we don't need to remove the kidney. But now, as we've analyzed the data over the last 10 years, removal of the kidney remains important.
I don't even remember how I ended up with the first physician. He was a kidney doctor who provided a very poor prognosis, just not good news. Dr. Vogelsang, of course, had a completely different take on the situation, and yes, it was a large tumor, and yes, it was serious. This is 6 years ago, and there weren't near the options there are now. He was realistic with us, but also very encouraging in what he felt could happen, in that this tumor could be removed and that we could have other treatments and be successful.
There are still some populations for whom removal of the kidney is not indicated. Those are usually the poor risk patients, patients with very difficult to remove tumors, but as one of my friends said, it all depends on the skill of the surgeon. I generally follow a principle of putting out the fire by giving the patients a TKI and then removing the kidney. I'm always concerned that the cancer may grow too quickly, so I tend to defer removal of the kidney for 3 to 4 months.
Careful patient assessment and attention to prognostic factors help individualize treatment of renal cell carcinoma.
In terms of assessing a patient for treatment, there's a lot of components to that. So one is just sort of simple staging, right? Where does the patient have disease? Some patients have more anatomically critical disease than others, meaning they have disease in their brain or weight-bearing bone or something that obviously needs local attention, surgery or radiation. Most people don't have that, and they just have, other systemic disease. When we're thinking about how to approach a patient, there are different prognostic systems.
The first was developed by Memorial Sloan Kettering, Bob Motzer. The categorization was simple, good, intermediate, and poor. Variants include things like LDH level, calcium level, hemoglobin level, presence or absence of the kidney in the patient, whether it's been removed previously or whether it's present at the time of diagnosis with metastatic disease. None of those risk factors is considered good risk. Intermediate is 1, 2, or 3 risk factors, and poor risk is 4, 5, or 6 risk factors. A more recent analysis has been the international classification, which is a little bit more precise and uses white cell counts and platelet count and stuff like that.
And they're fairly overlapping. I think people use those to varying degrees.
The good risk patients will have survivals measured 5 years and beyond. Then there's the intermediate risk, which is the large population, 60+%, who have seen the most benefit over the last 5 to 10 years. And then the poor risk patients, they're the tough ones. We've moved the needle on them from maybe 3 months on median to perhaps about 10 to 12 months. And if they happen to get a response, they'll do very well. But you can't know how well they'll do until you treat them.
Join us next time when we discuss the factors to consider in the selection of first-line therapy for patients with metastatic renal cell carcinoma.